Hello, my name is Patrick and I'm in Cairns. I'm doing skill 1, which is a demonstration of both needle and pneumocath thoracostomy, which is indicated for tension pneumothorax with respiratory or hemodynamic compromise. And in Queensland, bilateral needle decompression forms part of the traumatic cardiac arrest algorithm. Tension pneumothorax is a pneumothorax, or air trapped in the pleural cavity under pressure that results in the lateral shift of the patient's mediastinum and obstructs venous return to the heart, eventually leading to obstructive shock and a likely PEA arrest. In QAS, all traumatic cardiac arrest with injuries to the torso are indicated for bilateral needle decompression. This reflects the fact that tension pneumothoraces can be hard to detect in the field, and decompression is one of the few reversible causes of traumatic arrest outside of hospital. Indications that a patient may have a tension pneumothorax include diminished breath sounds on the affected side, dyspnea, tachypnea, persistently low oxygen saturations despite oxygen therapy, subcutaneous emphysema and agitation. Other late signs are hypotension, jugular vein distension and tracheal deviation. Importantly, these late clinical features may be hard to detect. One should have a high degree of suspicion in any patient that presents as tachycardic and hypotensive, particularly if they've been ventilated. In Queensland, we carry the Cook Emergency Pneumocath set, which comes in two sizes, one with a cannula length of 6 centimetres and the other with a length of 8.7 centimetres. Also contained an individually packaged introducer needle, chest drain valve, connecting tube, 12mm syringe, Molnar disc and one-way stopcock. Queensland ALS crews do not carry pneumocaths and instead would use a 14-gauge cannula. There are some important differences, one being the length of the cannula, 4.5 centimetres. A 2015 meta-analysis found that a catheter of at least 6.44 centimetres in length would be required to ensure that 95% of the patients would have penetration of the pleural space at the site of needle decompression and therefore a successful procedure. Another issue with the 14-gauge cannula is their tendency to kink, rendering them non-operational. The cannula in the Cook pneumocath set is much more robust. Other important equipment includes the PPE gear and antiseptic. This is a highly invasive procedure, so aseptic technique is crucial. The primary site for decompression is the second intercostal space mid-clavicular line. However, this may not always be possible, for example, due to injury or the presence of an internal cardiac defibrillator. Another option is the fifth intercostal space anterior axillary line. This site may have some advantages, for example, a more narrow chest wall. However, it may also be harder to access and also may be dislodged by the patient's arm. When locating the sites for decompression, ideally you want the patient lying supine or on a stretcher without a spine board or scoop stretcher behind them, as they may roll the patient's shoulders forward and conceal the anatomy. Okay, so the first step is palpate the length of the clavicle and find the mid-clavicular line. And the second step is to locate the angle of Louis, track across to the second rib, follow the rib along to the mid-clavicular line, and the insertion point is just superior to the third rib. Okay, so the second spot is the fifth intercostal space anterior axillary line. So locate the anterior axillary line and then count down from the angle of Louis from the second rib to the fifth. And then track along the fifth rib. And the same principle as before, just superior to the sixth rib. Okay, so this is the setup. Everything is open but still rests within its packet to keep it aseptic. And I am wearing my full personal protective gear, including face mask and glasses. And the syringe with 5 mils of saline is attached to the cannula, and we're ready to go. Okay, so we're ready to go. Locate the mid-clavicular line as shown before. And the second rib, track across. Okay, so perpendicular to the chest, while drawing back on the syringe with the dominant hand. When air aspirates in, don't advance the needle anymore against the pan. Remove, sharp spin, flange, and attach. connecting tube and the one-way valve. Okay, so using the 14 gauge cannula, the process is the same. Locate the mid-clavicular line. Let's track across the second rib, second intercostal space, superior to the third rib. Insert perpendicular to the chest. And draw. Okay, if you feel that subsequent insertions are required, you would go lateral along the second intercostal space. On this dummy, it doesn't allow you to go, there's no space for the fifth intercostal space. Mid auxiliary line, but the process is the same. It's perpendicular to the chest, exactly the same as before. Importantly, if you're doing this in the setting of a traumatic cardiac arrest, it's better to do the right side first. And the reason for that is, if there was a tension pneuma on the right side pushing the mediastinum over to the left, if you were to go left side first, you've got a much higher chance of striking a major artery or the heart itself using the pneumocat. So yeah, in that setting, definitely go right side first.